I'm going to go over some information about some general information that you want to gather from your client when you first meet them, and also apply it to the case study. And so this list of general topics are the basics. Why are you here? What is your subjective or description of your illness? What's the history of your illness? What medications are you on? Allergies? What's your past? And also in terms of some risk factor and barriers, family history, whether or not somebody has support is social history, and then also exercise history. We want to be sure that the individual is aware of the reason that they're there. The certified exercise physiologist may need to further educate that patient if they have a physician recommendation of what kind of expectations or goals that they have for the program, but we also want to make sure we understand what the patient's personal goals are. Demographics are those descriptor characteristics of age, sex, and ethnicity. And I will mention to you, we do have challenges that no textbook talks about, and that is if somebody is a transsexual. And so what do we do with norms if somebody is in the process of changing their sex? So I just want to mention we want to be open and ask for preferred pronouns, and also be mindful of setting an inviting, comfortable, open, non-judgmental circumstance for our interaction with our client. The history of the present illness will help you to better understand what why the person is there, what they're complaining about, what they have in their life that they want to address. If they have any kind of numbness, tingling, burning sensations with the nervous system dysfunction or alterations of blood pressure, it could be hypotension, any other diseases that they have, and their symptoms. The symptoms, the mnemonic is as follows. O is onset, a description of when, what did this happen, or these symptoms happen suddenly, or was it gradually over time? Provokes is what makes your pain better or worse. Q is describing your pain and discomfort. That could be, is it burning, stabbing, tingling, etc. R is for radiates, and that could be asked by asking the individual to point to where the discomfort is the most and say, oh, where does your pain or discomfort go from there? So you can know if they have hip pain, does it go down toward their knee, for example. S is severity. That could be a scale of 0 to 10. And that somewhat goes with quality, so you can ask that at the same time. And T is time. When did the symptoms begin? How long have you had this diagnosis? Has your disease changed over time? So getting kind of a historical perspective. And finally, A could be what alleviates your symptoms. How do you adapt with your disease? So that OPQRST is helpful with getting a clear understanding about their history, their present history of their illness. We always ask about chest pain in the history and physical. When you do the PAR-Q anytime. I know people will say, I have chest pain when I run up the stairs. Well, there's typical, and that is when chest pain that is atypical is sharp stabbing, pricking, tingling, and it doesn't radiate. And it can happen at any time. Typical that we want to worry about is squeezing, left chest. It radiates to the neck. It's our typical cardiovascular chest pain experiences. The non-cardiac is usually when someone says, oh, I get shortness of breath when I run up the stairs. They might say that that's chest pain, but we want to have those words in terms of descriptors with quality and radiation and what exacerbates it. That will help us to understand a little bit more about the cardiac concerns that we would have with our clients. We really want to know what medications a person is on. We want to make sure that we know all of the dosage information. We also want to know if they have any allergies. So I think I'll go over a little bit more about cardiovascular medications in another presentation. We want to know any cardiovascular or coronary artery disease, history, dates, times, when, what, where. We want to know anything about a stroke or peripheral vascular or peripheral artery disease. And we also want to know about lung disease, because those are going to be really important pieces of information for us with making our recommendations for physical activity. What we do know from our first case study is that we've gotten some information about her family history, a little bit about her social history, and also about her personal goals and what kind of social housing she has, what kind of social support she has. So she's 48. She's a black female. She is not the singularly raising 2 young grandchildren, but she has 2 young grandchildren in her home. She does work for an internet company, and she says it's really stressful. Her primary care physician said that, or indicated, her blood pressure and cholesterol levels are high, and she has a tremendous amount of stress at home and with her job. She also indicates that she is interested in losing weight and wants to be more active. Now, in terms of her family history, we get to know a little bit about her sister, who was recently diagnosed with diabetes. Now, we're going to assume that that's type 2 diabetes, but this tells us that she does have some concern about her own health, getting to that age of 48 and somewhat concerned. So with our general information, we don't know her family history in terms of her parents, but we do know that her sister has diabetes. We don't know anything about, we know she's married. We know her occupation is probably a sedentary job. Although we don't know what kind of housing that she lives in and her transportation, but that is something that is worthwhile to know, right? We would like to know what kind of neighborhood she lives in, if she has access to walk outdoors, if she has parks available, etc. That really helps with making recommendations. So she says she's not physically active. She's 48, and at the age of 18, when she graduated, most likely she was on the track team. So she understands what it feels like to be active and how she feels when she is active. She knows it would be good, but she has that constant thing when you have small children in your home. Time is really difficult to find for yourself. And she does talk about her barriers in terms of time, access, suggesting that she might have some challenges, financial challenges, and but she really hasn't considered anything, but she's interested in starting. So she does have some interest, although she has some common barriers that are in place. Ideally, we would want to know if a person, how active they are, what kind of, we do know her prior physical activity is that she was on, she ran, so she did like to run, but we also know that she's overweight or obese, depending on what her BMI is, and that she's not physically active now. So we don't want to start, even though she did like running, we aren't going to start her there. We don't know anything about her Sleep patterns or snoring, sleep patterns and snoring are helpful for sleep in particular. If she's not getting enough sleep, that's a risk factor for obesity. If she snores, that could be cardiovascular risk with sleep apnea. We would want to look at all of her systems, and most of this is done by a physician in terms of the review of systems. A great way to identify what someone's capacity is by asking some example metabolic equivalent tasks examples. So when you're getting a question about do you exercise regularly, she can say no. You can ask if she mows her lawn, if she does her grocery shopping, can she carry her groceries into the house? Questions that are equivalent to metabolic equivalence, which can be helpful even if you don't have an exercise test, because you can get an idea about capacity of aerobic capacity. Although you're not doing a formal physical examination, you can make some assessment of a person's general state by just evaluating what somebody's visual, if they're upbeat, if they're distressed, if they're anxious, if they're wiggling, if they look like they're fatigued, how they if they slouch, if they look kind of, if they look really healthy and well nourished. So some general state of assessment is relatively easy to do. You will have an opportunity to assess blood pressure, and this is where you would look at hypertensive or hypotensive if they have any symptoms. Sometimes people will come with, if you measure their heart rate, they're very anxious. That would be unexplained tachycardia or a very low heartbeat. It would be if somebody is a aerobic athlete, their heart rate can be very low. Below 40 is unexplained, typically unexplained bradycardia. So what we do know is she is 66 inches tall, she is 196 pounds, and her BMI is 31.7. Her resting heart is 85, and her blood pressure is 136.89. So we know that she's on borderline hypertensive. And that's a normal resting heart rate. It's within normal limits. But her BMI is 31.7, which is elevated. We do know that certain drugs will have an impact on heart rate, and this is where we want to know what kind of medications people are on, and if for example they're on a classification of drugs, cardiovascular drugs called beta blockers, that will have an explanation of why someone has a low heart rate. If they are breathing fast and heavy, we want to be mindful of that. It's unlikely that you will have a that you'll be assessing hypoxia, but that would be in the diagnosis if it was the case. And if they're breathing really slowly, that should be part of the information that you get from the physician. The simplest way of getting an overview of body mass assessment in terms of risk factors is looking at their body mass index. Now we know that that is not a great tool for our healthy individuals, but for a 48-year-old woman who is not exercising regularly, I think we can feel pretty confident that the BMI is going to be a useful tool for screening. And in this case, we're looking at a risk factor of greater than 30 as being a positive risk factor for cardiovascular disease. So she is in that classification of having that positive risk factor. We know that the risk factor, if we had it, sometimes in case studies we'll get the waist circumference greater than 40 or greater than 35, and I'm looking at table 2.2, and that has your risk factors. We also would like to know, I think it would be great to know what the waist measurement is, because we get an idea about potential other diseases that she's at risk for, and that would be diabetes and also dyslipidemia. We can look at her classification of her body mass index, and there is a nomogram. I guess, would that be a nomogram? I guess this would be a figure where you put the height and the weight and you cross over with the body mass index, and you'll be able to identify what classification someone is in terms of obesity, overweight, healthy weight, or underweight. So that's also another way to evaluate it. When we get to respiratory diseases, the physician will have evaluated breath sounds with auscultation, and that is where you put the stethoscope on the anterior and posterior chest wall, and you're listening for, the physician is listening for sounds, and whether or not wheezing, crackling, and with these we're looking at pulmonary system contributions, and we would have that information in our case study. The cardiovascular system, again, this is the physician looking at this, or if you're in a clinical setting, looking at the pulses, or assessing the cardiac pulse and observing the breathing, and that undoubtedly would be physician or in a clinical setting. This, in terms of the cardiovascular system, the physician will auscultate and listen for murmurs, grade the arterial pulse in different locations, in the, like in the ankle, would be an example of place to look. Any place where an artery is next to the surface of the skin in a bone, you can measure arterial pulses. And in the ankle, that's where it's evaluated to look at circulation. But it is pretty easy to see if somebody has really swollen ankles, legs, or feet. You want to pay attention to that. It could be a sign of heart failure or congestive heart failure. Some medications might have minor edema, and that's again why you want to know their medications. For the musculoskeletal system, there are some assessments that we can do, and this is in the functional assessments. So a sit to stand, watching a person walk, and in the next module you'll look at some functional assessments that can be done. Range of motion, paying attention to warmth, swelling, and tenderness, and then also doing an assessment of muscle strength. These are the assessment of range of motion and muscle strength is often a physical therapist's assessment at the first meeting. And so I'm introducing those to you, but that doesn't necessarily mean this is what you will do. These are the common joint movements in terms of flexion, extension, and so forth. Just a little reminder. And spend a lot more time in the functional fitness and balance type of assessments. The functional fitness test, the 6-minute walk test, sit to stand, timed up and go, that's described later. The 10-meter walk test is one for balance and risk of fall. The Berg Balance Scale, there's a 14-item exam, which is used very frequently in the physical therapy setting. Other components that are evaluated would be discomfort associated with back pain, arthritis, hypo, or any kind of numbness, tingling, response to the thump on the reflexes, nervous system, that would be that. Looking for any kind of signs and symptoms of anemia. Clubbing is going to be associated with anemia. That's at the most distal skin, most distal joint of the fingers, and look at feet, especially for diabetes, people with diabetes, that they have any kind of open wounds, blisters, etc. And then laboratory data and diagnostic testing. So the discussion questions that go after that would, based on the medical history, what is the primary disease of concern? Well, she really has only risk factors, and we have to look a little bit at the whole picture. We know that in table 2.2, if we looked at her risk factors, she doesn't have age is not a risk factor because she's under 55. We don't know about her family history, but we do know that in terms of cardiovascular disease or sudden death, we don't know anything about that with her family, so we have to assume it's a yes. Cigarette smoking, that would be something you would want to know. Although we don't know, we would have to say a yes. Physical activity, she's not meeting the threshold, so that would be a risk factor. Her body mass index, that's a risk factor because she's above 30. Blood pressure, that's a risk factor because her blood pressure is greater than 130. Her lipids, we ultimately know that her her HDLs are low, and that is in women with non-HDL-C less than 130. We know that her HDLs are low, and so we actually don't know what her HDL, what her low density lipoproteins are, but she's got a risk factor in lipids, and we don't know about her blood glucose. So she's got a number of risk factors based upon how we evaluate them. So she has significant risk factors for cardiovascular disease. We do know that. Her patient's diagnosis and comorbidities, well, she's a healthy, middle-aged female with risk factors for cardiovascular disease. We also know that she is identified as being overweight by 30 to 40 pounds, but we don't see any signs and symptoms of cardiovascular, renal, or metabolic disease, and that is on table 2.1. And you find that in your guidelines book on page, where is it? 33. Are there recommendations for medical clearance to exercise or become physically active? We know if we use the flow chart on page 35, she doesn't participate in regular physical activity. She doesn't have signs or symptoms suggestive of, well, she does have signs or symptoms. So medical clearance, what we do know is if she was to start with vigorous exercise, she would need an exercise test. But she does not need it to start with light to moderate. And so she doesn't, but she has already been to the physician. She has made a recommendation. And so in a way, this is a moot point for question D. Is an exercise test required? And I'm going to say no, because it's not required if she starts with low to moderate physical activity. But she did have an exercise test because of the number of her physician had one probably because of the number of risk factors that she had. Does she have any absolute or relative contraindications to exercise testing? What you will need to look at is box 4.1 on page 116. She does not have any absolute or relative. So the answer to that is no. She does not have any relative or absolute contraindications, box 4.1. F, she isn't on any medications, so we don't have anything that we need to be concerned about. We do find out what her cholesterol is, and what her HDL-C is 34. And if we go back and look at our risk factors, we see that her HDL-C is less than 40, so that's a positive risk factor for lipids. The other diagnostic test results, it says no other tests were provided, but however, yes it was. She did have a VO2 max test. And we're going to assume this is a symptom-limited graded exercise test. And as her graded treadmill stress test reveals, it's an exercise, probably a symptom-limited test. She has a VO2 max of 20.5. And if we look at table 4.1, and I'm doing a quick check to table 4.1. We'll find that, 4.3, that's not the right table. Table 4.3, which is on page 121, we know that we have the practices for before exercise, during exercise, and after exercise, what information we should be obtaining, and what was in the order in terms of what we assess and when we assess it. Unfortunately, we do not know any of that information. Table 3.8 has the classifications of VO2 max, and her fitness level, normal for an unfit woman of her age, she's actually in the 5th percentile. Is that normal? I'm going to disagree with that. And so that's part of what we're doing here. We can disagree. We can disagree. That's part of what this practice is about. So are there any results from the examination or chemistry or anything that we need to be aware of? Well, she has some joint pain, but it shouldn't impact. I think what we do need to understand is that she is obese, not morbidly obese, and she also has some joint stiffness, but I really don't think that's going to make any trouble for us, so I'm going to say none. B, are there any considerations regarding the safety? I think as long as she starts at a low to moderate intensity, the risks and safety are extremely low. The exercise plan that we're supposed to put together is to look at the frequency, intensity, duration, and modality discussed in later chapters. Well, we're going to talk about that a little bit. She has not really wanted to do any activity, but we're going to work on getting something done for her, because I think part of our job is to encourage people to begin to get active, but this tells you that we have to be careful and be supportive for her and get other people supportive for her as well. So based on the information, what do you need to consider? Well, you got to consider her barriers, childcare, time. She doesn't have a high level of internal motivation, but she has some external motivation. Hopefully we can improve that. Right? So that's something that we need to consider. And what would we expect? Well, hopefully we would expect her to have lower blood pressure, potentially have more energy for her day-to-day, reduce stress, improve her HDL-C, and have some weight loss. Is there B? Are there any signs and symptoms that need to be considered? And I'm going to say no, there really aren't. So the time that you get to be creative is putting together an exercise program. What we don't know is what she likes to do. And so when we get together, this is the kind of stuff we're going to talk about. And it's not necessarily in books, but I think when you work with a client, especially somebody who has a chronic disease, we have to address what they want, what their goals are. And this is one of my favorite statements that I've learned in my duration of education. Give them what they want, sneak in what they need. So we want to encourage her to do a little bit more, increase her activity, but also recognize she doesn't have a lot of internal motivation. So what does she like to do? When does she have time to exercise? What are her available resources? We have to just guess, because those are questions that we would want to ask more when we put her program together, because it's her program. She has a seated job. So I'm thinking it would be great to start to introduce 10 to 15 minutes of walking during her lunch break, because she said time is a problem. Doing something, and I like to ask, would you be able to walk 10 to 15 minutes during your lunch break? What's the likelihood that you would be able to do that? We want to assess that motivation and also be able to identify if it's possible. If it's not, adjust. We want to encourage her to progress her days per week and her time in a meaningful way over those 12 weeks. So I'm just projecting, and hopefully I would be able to talk to her during this time and see how she responds. This might be way under what she can do, and also might be way under what she wants to do, or it might be more than she can. So it's keeping in touch. So this is just a starting point. I like to encourage the aerobic initially and start to encourage her to do body weight exercise. The body weight exercises 2 to 3 days per week. I like to start with a cardiovascular and then get the resistance in. That is really going to be the most important part of getting that weight loss, and it certainly is necessary to do that. We used to, we just need to have the combination. I would like to encourage her to start flexibility exercises at work by doing some gentle seated stretches in her chair that involve her neck, her shoulders, her back. Where does she carry her stress? Start to introduce whole body stretches once she gets used to it, and usually she'll probably start to like that. Eventually, I wonder if she would like encourage daily stretching, and maybe she could do some yoga. Maybe there's online yoga that she could be introduced to. I also want to mention that a tool that might be really interesting for her to monitor would be a pedometer. What's her baseline number of steps? This is an alternative way of doing it. And get her baseline, and can she increase 1,000 steps per day or two until she gets to 10,000, and ultimately getting to 12,000 per day or more. So we've got to consider her time, introduce it at low intensity, low to moderate, and then she can progress to vigorous. But we want to start where she's at. Also, I want to point to you the frequency, intensity, type, and time recommendations are on page 298, because really the obesity is the concern. And finally, there are a few other questions. What issues might be a problem? Well, it's her barriers. Talking with her about alternatives. If she says time, then we want to say, well, what kind of, when do you have, can you separate it into 10-minute bouts? Are there 10-minute time frames that you can take a walk for 10 minutes rather than 30 minutes all at once? Can she use her lunch hour? Can she go for a walk with her spouse or her partner? Can she get her grandkids active by going to a pool if it's available? Maybe go to a park. Considerations that impact workload or intensity, that would be perhaps her joint stiffness or risk of injury associated with obesity. So perhaps alternating non-weight bearing activities like cycling, or does she have access to a pool? This could be a potential might impact. So that's letter E. And letter F, I think that a stress reduction program and also a diet modification program would be important. And this is about staying in your own lane. So if you can introduce minimally deep breathing exercises when she's at work, 5 deep breaths, very simple to do, very easy to teach, making some for diet modifications, you can do some basic recommendations, but if she has risk for diabetes, she might need to have expert recommendations that could be done by a registered dietitian. So those would be some potential resources that might be helpful. And that is the story, Morning Glory.